Okay, moving on to the mycobacteria. These are the acid-fast bacilli. They're gram-positive, and of course they're irregular. They're acid-fast staining, which means that they have a lot of lipids in their cell membrane, and so they don't stain completely. There may be variations of color or more than one color there. Those that are positive will often stain such a light purple that it appears pink. They are strict anaerobes and produce catalase. There are no capsules, flagella, or spores, and they grow very slowly. You see the difference in the colors there? You have lights and darks. Now, Mycobacterium tuberculosis is also called tubercle bacillus. These are long, thin rods, and they grow in these sinuous masses or strands that are called cords. And that is a virulence factor for them because along with the waxes in their membrane, that prevents destruction by the lysosomes and the macrophages. It doesn't make any exotoxins or enzymes that help it to be more infectious. Now, the predisposing factors would be inadequate nutrition, a compromised immune system, poor access to medical care, lung damage, or even genetics. A third of the world population and 15 million in the United States carry tubercle bacillus. And this, we find a high rate of this in our recent immigrants. It's very resistant and it's transmitted by airborne respiratory droplets. About 5 to 10% of infected people develop the disease. It progresses very slowly, and most of it stays contained in the lungs. But we can divide clinical tuberculosis into primary tuberculosis, secondary tuberculosis, where it reactivates or you get reinfected, and then disseminating tuberculosis. The infectious dose is just 10 cells, and they get phagocytized by your macrophages in your alveoli, and they multiply intracellular. And then after 3 to 4 weeks, your immune system attacks it, and this forms these tubercles, which have a central core that contain the bacilli, and it's surrounded by white blood cells called tubercles. And the center of the tubercle can break down and become necrotic caseous lesions that will heal by calcifying. So you have these calcified lesions that show up in your lungs usually. Now, if a person doesn't recover from the primary tuberculosis, the bacilli can reactivate, and the tubercles will expand and drain into the bronchial tubes and the upper respiratory tract. Usually there'll be violent coughing, greenish or bloody sputum, fever, anorexia, weight loss, fatigue, and if it's not treated, there's a 60% mortality rate. And when you have this reactivated TB, the bacilli move into the lymph nodes and the kidneys and the genital tract and your bones and your brain and your meninges, so it can have grave complications. How do we detect it? We're all familiar with this tuberculin sensitivity test, the MANTO or MANTO test, where they do the local intradermal injection, and you look for this red wheel to form between 48 and 72 hours, and there's guidelines for the size of it and all that for interpreting it. There's also an in vitro TB test. There are 2 of these that the CDC has accepted. There's chest x-rays. You can rule out pulmonary tuberculosis, but it's not really diagnostic. The acid-fast staining of the sputum or specimens is used, and then the most accurate diagnosis is from cultural isolation and biochemical testing. You see the tubercles over on the left in the lungs. Now, to treat it and to maintain it, we're going to have to take 2 drugs about 6 to 24 months. And there's a choice of 11 drugs there. A lot of the strains are resistant to at least one of them. The most common treatment begins with the initial phase of the 4 drugs, INH, RIF, EMB, and PZA. And you take these every day for 8 weeks. And then you have a continuation phase where you take daily doses of the INH and RIF for 18 more weeks. So tuberculosis is spread via respiratory droplets.